So we're all here to make our surgical patients do better. We'd all like to do quality improvement. But why is it so hard? What's the usual way we have done surgical quality improvement in the past? Everybody will recognize this who's been in surgery, and most of the anesthesiologists will recognize it. Something goes wrong. Patient dies, patient gets a complication, bunch of people get into a room, a sentinel event happens, bunch of people get into a room, there's a lot of gnashing, a lot of talking, there's some finger pointing, there's some blame that goes on, and you think you've solved the problem, you've slapped somebody on the wrist, says don't do that again, and that person leaves and they'll never do it again. What about the next surgeon? What about the next anesthesiologist? You've not done anything to change the system. So why is it so hard? There's really one reason that's paramount. That's habit. We as physicians like to do the same thing again and again and again and again. We get into a habit. And habit is very good for us because it improves our efficiency. When we do the same thing again and again and again, we're much more efficient. When we're asked to change, somebody asks me to do something different, all of a sudden I slow down. That costs me time, effort, frustration. That's not very good. I don't like to change. And of course it costs money. Time is money. Hospital administrators don't like doing things new. If I slow down the hospital efficiency, I'm costing the hospital money, et cetera, et cetera. So those are the reasons why surgical quality improvement is very hard. So why am I up here talking to you? My background, I'll go through this really quickly. The basics of this is I'm old, I've been around, I've done a lot of things, I hold a lot of titles. And in my 60s, I was able to change. So I really give it to the surgeons and anesthesiologists who are in their 40s and have been in practice for 5 or 10 or 12 years and who can't change what they do. I changed in my 60s. To understand a lot of what I'm talking about, we need to differentiate what we call a process measure from an outcome measure. A process measure is skip. We know skip. That's what you do to the patient. Do you give them their antibiotic? Do you give them their beta blocker? Do you keep them warm? Those are process measures. Outcomes measures is what happens to the patient. Did they have a perioperative MI because you left out their beta blocker? Did they have a surgical site infection because you messed up their temperature control and antibiotics, etc.? So what happens? So it's process measures versus outcomes measures. And we're going to try to keep those differentiated as we go. As you know, CMS has had skip part of pay for performance. But fortunately, it's disappearing. It used to be 40% of the value-based purchasing, which means the 40% of the difference Medicare would pay a hospital was based on skip. Well, it's going down to 30 this year, 20 next year, 10% in 2017. We don't know what's going to happen after that. I hope it disappears. It's being replaced by outcomes measures. Your hospital is going to be reporting more and more surgical outcomes to CMS, and those outcomes are going to determine what your hospital gets reimbursed. It's starting 20% in 2015, 30% in 16, 40% in 17. It's replacing skip, so we're going to outcomes measures. Now, CMS has contracted with NSQIP. I'm going to talk a bit about NSQIP. Who's a NSQIP hospital? Not that many. I'm going to do a bunch of talking about NSQIP. I'll talk about NSQIP for those of you who don't know about NSQIP. I don't care if you're NSQIP or not. It won't matter. But CMS has contracted with NSQIP to provide outcomes measures for the purpose of pay for performance. For those hospitals that are not NSQIP hospitals, they're going to be using administrative databases. What's wrong with administrative databases? So I see somebody nodding and smiling. It's a built-in minimum 20% error rate, and every time it's ever been studied. So in 2014, at the beginning, there were 400 hospitals in NSQIP participating, and when NSQIP contracted with CMS, boom, that jumped. There's now 650. I think there's now 673 last time I looked, hospitals who joined NSQIP. You don't need to be in NSQIP. The other thing that's going to change is by 2017, the outcomes will be physician-specific. CMS Hospital Compare is out there. You know that. It's been open for several years.